Uterine fibroids are incredibly common benign tumors that grow in or on the wall of the uterus. The word tumor can be frightening, but it is essential to understand that fibroids are almost never cancerous and are not a form of uterine cancer. It is more accurate to think of them as dense, muscular knots that grow within the normal muscle of the uterus. They are, in fact, the most common pelvic growth in women, affecting up to 80% of women by the time they reach age. The prevalence is even higher in Black women, who are also more likely to develop fibroids at a younger age and with more severe symptoms. For many women, fibroids cause no issues and require no treatment. For others, they can cause significant problems like heavy menstrual bleeding and debilitating pain that can disrupt daily life. Understanding what fibroids are, the symptoms they can cause, and the wide array of modern treatment options is the first step toward managing this very common condition and making informed decisions about your health and well-being. Fibroids, also known by their medical name, leiomyomas, or classified based on their location within the uterus. Their location is the primary factor that determines the types of symptoms a woman might experience. Intramural fibroids. These are the most common type of fibroid. They grow within the muscular wall of the uterus, called the myometrium. As they grow, they can make the uterus feel larger, sometimes causing significant pressure or a feeling of fullness in the lower abdomen. Large intramural fibroids can also expand inwards, distorting the uterine cavity and leading to heavy bleeding, or expand outwards, causing bulk symptoms similar to subserosal fibroid. Submucosal fibroids. These fibroids grow just underneath the inner lining of the uterus, known as the endometrium. Even very small submucosal fibroids can cause significant problems because they bulge into the uterine cavity. They disrupt the uterine lining, increasing its surface area and leading to very heavy prolonged menstrual bleeding. By preventing the uterine muscle from contracting properly, they also make it harder for the body to stop menstrual bleeding. This type is most likely to interfere with fertility by affecting embryo implantation or causing miscarriage. Subserosal fibroids. These fibroids grow on the outer surface of the uterus, bulging outwards into the pelvic cavity. They do not typically affect menstrual flow. Instead, their symptoms are related to their size and the pressure they exert on surrounding organs. A large subserosal fibroid pressing on the bladder can cause frequent urination or even stress incontinence, which is leaking urine when you cough or sneeze. If it presses on the rectum, it can lead to constipation and a feeling of rectal fullness. Pedunculated fibroids, sometimes a subserosal or submucosal fibroid, can grow on a stalk called a pedicle, giving it a mushroom-like appearance. These are called pedunculated fibroids. If this stalk twists on itself, it cuts off the fibroid's blood supply. This event, known as torsion, is a medical emergency that causes sudden, sharp, and severe pain and requires immediate medical attention. A woman can have a single fibroid or dozens of them, and they can vary in size from as small as a seed to as large as a melon. The exact cause of why fibroids develop is still not fully understood, but research points to a complex interplay of hormonal, genetic, and environmental factors. Hormones, the female reproductive hormones, estrogen and progesterone, are clearly the primary drivers of fibroid growth. Fibroids have a higher concentration of receptors for these hormones than normal uterine muscle cells do. This makes them very sensitive to the circulating hormones produced by the ovaries. This hormonal sensitivity is why fibroids tend to grow during the reproductive years, when hormone levels are high, and often shrink after menopause when hormone levels decline significantly. Genetics. There is a strong genetic component to fibroids. They often run in families. If your mother or sister had fibroids, your risk of developing them is about 3 times higher than average. Researchers have identified specific gene mutations, particularly in a gene called MEDED12, that are present in a large percentage of fibroids. This suggests that a genetic predisposition can make uterine muscle cells susceptible to developing into fibroids. Other factors seem to play a role in their development. The onset of menstruation at an early age gives hormones a longer time to influence the uterus. Obesity is a risk factor because fat cells can produce estrogen, increasing overall exposure. A diet high in red meat and low in fruits and green vegetables has been associated with a higher risk. Conversely, some studies suggest a diet rich in fruits, vegetables, and green tea may have a protective effect. A deficiency in vitamin D is also being investigated as a potential risk factor. The clinical journey of this condition. For other women, fibroids can grow and begin to cause symptoms that can worsen over time. The growth of fibroids is often slow but can be unpredictable. They can remain the same size for years, grow slowly, or sometimes have periods of rapid growth. During pregnancy, fibroids can sometimes grow quickly due to the high levels of hormones and increased blood flow to the uterus, though many do not change in size. After menopause, without the stimulation of estrogen and progesterone from the ovaries, most fibroids will stop growing and shrink, and symptoms often resolve completely. It is extremely rare for a fibroid to become cancerous. The risk of a cancerous fibroid, called a leiomyosarcoma, is less than 1 in 1,000. The most common symptoms include heavy or prolonged menstrual bleeding. This is the hallmark symptom. Medically, heavy menstrual bleeding is defined as losing more than 80 milliliters of blood per cycle. In practical terms, this means soaking through a pad or tampon every hour for several consecutive hours, needing to wake up at night to change protection, passing blood clots larger than a quarter, or having periods that last longer than 7 days. This chronic blood loss frequently leads to anemia, a condition caused by low iron levels. The symptoms of anemia are not just tiredness. They include profound fatigue, weakness, pale skin, shortness of breath, dizziness, cold hands and feet, and even hair loss. Pelvic pain and pressure. Larger fibroids can cause a feeling of heaviness, pressure, or a dull ache in the pelvis or lower abdomen. Many women describe it as feeling constantly bloated or even looking several months pregnant, a phenomenon often called a fibroid belly. This can make it uncomfortable to bend over or lie on your stomach. Frequent urination or difficulty emptying the bladder. A fibroid pressing on the bladder can reduce its capacity, leading to a frequent need to urinate, even at night. Sometimes it can press on the urethra, making it difficult to start a stream of urine or fully empty the bladder. Constipation or rectal pressure. Fibroids on the back of the uterus can press on the rectum, causing constipation, pain during bowel movements, or a feeling of rectal fullness. Backache or leg pains. A large fibroid pressing on nerves in the back or pelvis can cause pain that radiates to the lower back or down the legs, similar to sciatic. Pain during intercourse. Depending on their location, fibroids can sometimes cause deep pain during sex. Getting professional help. Diagnosis and evaluation. If you are experiencing symptoms suggestive of fibroids, it is important to see a gynecologist or a family doctor for a proper evaluation. The diagnostic process is straightforward. 1. Medical history and pelvic exam. Your doctor will discuss your symptoms and medical history. During a pelvic exam, your doctor can often feel if your uterus is enlarged or has an irregular, lumpy shape, which can suggest the presence of fibroids. 2. Imaging studies. Ultrasound. This is the most common and effective tool for diagnosing fibroids. A transvaginal ultrasound, where a small probe is placed in the vagina, provides the clearest images of the uterus. It can confirm the presence of fibroids and accurately map their size and location. Saline infusion sonogram. In this procedure, sterile salt water is injected into the uterus to expand the cavity, making it easier to see submucosal fibroids on the ultrasound that might be affecting the uterine lining. Magnetic resonance imaging, or MRI. An MRI provides the most detailed picture of the fibroids, showing their exact size, number, and location in 3 dimensions. It is often used to help plan for complex surgeries or to distinguish fibroids from other, rarer uterine conditions. A wide range of treatment options. The treatment for fibroids depends on many factors, including the severity of your symptoms, your age, your desire for future pregnancy, and your personal preference. Watchful waiting. If you have no symptoms or only mild symptoms, the best approach is often no treatment at all. Your doctor will monitor the fibroids over time. Medications. Medications for fibroids aim to manage symptoms, primarily heavy bleeding. Hormonal contraceptives. Birth control pills or hormonal IUDs can help control heavy bleeding and make periods less painful, but they do not shrink the fibroids. GnRH agonists. These drugs block the production of estrogen and progesterone, creating a temporary menopausal state. This causes the fibroids to shrink and bleeding to stop. They are typically used for short periods to prepare for surgery. Tranexamic acid. This is a non-hormonal medication that can be taken during your period to reduce heavy bleeding. Minimally invasive procedures. Uterine fibroid embolization, or UFE. In this procedure, an interventional radiologist makes a tiny incision in the groin or wrist and threads a catheter to the arteries that supply blood to the fibroid. Tiny particles are then injected to block the blood flow, causing the fibroids to shrink and die. Radiofrequency ablation. Procedures like Acessa or Sonata use heat to destroy fibroid tissue. A probe is inserted into the fibroids, either laparoscopically through the abdomen or transcervically through the cervix, and radiofrequency energy is applied to shrink them. MRI-guided focused ultrasound surgery. This non-invasive procedure uses high-intensity ultrasound waves, guided by MRI, to heat up and destroy fibroid tissue from outside the body. Surgical treatments. Myomectomy. This is a surgical procedure to remove the fibroids while leaving the uterus intact. It is the preferred option for women who want to preserve their fertility. A myomectomy can be performed in several ways: hysteroscopically through the cervix for submucosal fibroids, laparoscopically through small abdominal incisions, or as a traditional open surgery, called a laparotomy, for very large or numerous fibroids. Hysterectomy. This is the surgical removal of the uterus. A hysterectomy is the only definitive cure for fibroids, as it eliminates the source of the problem. It is a major surgery and ends a woman's ability to become pregnant. The decision may also involve whether to remove the cervix, a total hysterectomy, or leave it, a supracervical hysterectomy, and whether to remove the ovaries, an oophorectomy, which would induce immediate menopause. Rehabilitation and living with fibroids. Rehabilitation depends on the treatment you receive. After a major surgery like a myomectomy or hysterectomy, recovery can take several weeks and will involve rest and a gradual return to normal activity. For less invasive procedures, recovery is much faster. Living well with fibroids often involves managing the symptoms. For heavy bleeding and anemia, it is crucial to have your iron levels checked and to work with your doctor on an effective iron supplementation plan, as over-the-counter supplements may not be sufficient and can cause constipation. For pelvic pain and pressure, over-the-counter pain relievers, heating pads, and gentle exercise like yoga can provide relief. It is also important to manage the emotional impact. Living with chronic pain and heavy bleeding can be exhausting and isolating. Seeking support from friends, family, or online fibroid support groups can make a significant difference. Scientists are working to better understand the genetic and molecular causes of fibroids, which could lead to new non-hormonal medical treatments that can shrink fibroids without the side effects of current medication. There is also ongoing innovation in minimally invasive procedures to provide women with more effective, uterus-sparing options. Leading medical experts emphasize the importance of individualized care and shared decision-making. Elizabeth Stewart, a leading fibroid researcher and gynecologist at the Mayo Clinic, has published extensively on the topic. A key theme in her work is the need for more research into the disparities in fibroid prevalence and outcomes, particularly for Black women, and the development of more patient-centered treatment options. She advocates for a careful discussion where a woman's goals and preferences are central to choosing a treatment path. The American College of Obstetricians and Gynecologists, or ACOG, provides clinical guidelines that support a wide range of treatment options. They state, fibroids are very common, and most do not require treatment. If you have symptoms, there are many choices available. You and your healthcare professional can discuss the best option for you. This underscores the modern approach to fibroid care, which is moving away from a one-size-fits-all model that often defaulted to hysterectomy. The expert consensus is clear. While uterine fibroids are common, you do not have to live with debilitating symptoms. From watchful waiting for asymptomatic cases to a growing number of medical and procedural interventions, women now have more choices than ever before. The key is to have an open, thorough conversation with your healthcare provider to find the treatment plan that best fits your life, your symptoms, and your future goal.